David Anders, Professor Anders, qualified in medicine at the University of Wisconsin in Madison in 1992 and became an ID physician studying there. And his interests remain the pharmacology of anti-infective agents. So he's going to give us a talk, Getting Antifungal Drug Levels Right. Why does it matter? David, thank you.
Thank you. I'd also like to thank Dr. Denning and the other organizers for this really unique opportunity to present to patients. And as mentioned, I'm going to talk about the measurement and management of antifungal drug concentrations, or the amount of antifungal that accumulates in one's body, often referred to in the scientific literature as therapeutic drug monitoring. So I'm going to discuss the management and monitoring of 3 antifungals that are used for the treatment of invasive aspergillosis. You can see here that not all antifungals that are used to treat invasive aspergillosis are included in this list. And the list includes 3 triazole drugs, voriconazole, itraconazole, and posaconazole. And I've included 2 pictures of itraconazole because there are 2 formulations, and the management of antifungal drug concentrations varies between these 2 concentrations. So what I hope to accomplish is to convince you that the amount of antifungal or concentration of antifungal that accumulates in the body makes a difference. So that you need enough for effective therapy, that concentrations that are too low results in ineffective therapy, and unfortunately, and not commonly, very, very high concentrations of the antifungal can result in toxicity. Secondly, I'd like to review some of the features that can impact how much antifungal accumulates in the body. And lastly, to review some strategies that help in modulating the amount of antifungal that accumulates in the body. But I'd first like to start with defining one pharmacologic feature that is common to all antifungal drugs that require monitoring, and that is unpredictable pharmacokinetics. To do that, I'd like to first show an example of predictable pharmacokinetics. So what I mean by predictable pharmacokinetics is that for any dose of antifungal, in this case fluconazole, that is administered, as you can see here, increasing antifungal concentrations on the x-axis, I can fairly reliably predict the amount of that drug that's going to accumulate in the body. So for any one given dose, I can predict how much is going to accumulate. Conversely, each of the 3 antifungals I'm going to talk about have unpredictable pharmacokinetics, and I show one example here. This is voriconazole pharmacokinetics in 8 healthy volunteers. Each of these patients, or healthy volunteers, excuse me, received the same dose of voriconazole, but you can see over time that the concentrations in their body varied very widely, from very, very low concentrations to occasionally very high concentrations. We would see the same thing with itraconazole and posaconazole, and in fact, in patients who are receiving these antifungals for treatment of invasive fungal infections, this pharmacokinetic variability is much greater than what I've shown here in this healthy volunteer data. I'd next like to take you through my very, very simplistic view of possible therapeutic outcomes in invasive aspergillosis, and I apologize for my feeble attempt to illustrate this. So here we have the human body that's infected in the lungs, a very common site of invasive aspergillosis, and here you can see the Aspergillus infection in both lungs. We have the esophagus, earlier referred to as the food tube. We have the stomach, the environment of which is very important for determining how much drug is going to accumulate in the body. And lastly, we have the liver that was introduced earlier as an organ that detoxifies the body and often alters the antifungals, affecting, again, how much active antifungal accumulates in the body. So the possibilities include, first, hopefully one receives the antifungal drug, accumulates in the stomach, hopefully is then absorbed, and begins to accumulate in the body, including the site of infection, accumulating to a higher concentration, and hopefully to a high enough concentration that the fungus starts to die and the patient starts to improve. Unfortunately, there are situations in which less antifungal accumulates in the body and at the site of infection, allowing the organism to continue to perpetuate and eventually cause additional damage. So too little antifungal drug accumulation. Very rarely, we can get the accumulation of too much antifungal. So even though we're accumulating enough antifungal to kill the fungus, it's also having a negative effect on the human. So I'd next like to show you an illustration of why antifungal drug concentrations matter. And because of time limitations, I'm not going to be able to take you through examples with each drug demonstrating that a certain concentration is needed for efficacy and too high a concentration results in toxicity. But I've included those slides that can be posted on the website for you to review at your leisure. The example I'm going to show you is an example with voriconazole therapeutic drug monitoring in patients with invasive aspergillosis. And this figure represents a summary of data from two studies. The first data set I will describe is represented by these two vertical bars. So this was a study, a retrospective study at our institution in Wisconsin, where we looked at therapeutic drug monitoring or voriconazole concentrations in close to 30 patients with invasive aspergillosis. And what you can see here is that we observed concentrations that were lower in this group of patients and concentrations that were higher in this group of patients. So you would rather be in this group of patients where nearly all of the patients survived when they had voriconazole concentrations that were greater than 2 micrograms per ml in the blood than in this group that had concentrations that were lower than 2 micrograms per ml in the blood. Interestingly, among the patients that initially were identified as having low concentrations of voriconazole, for a subset of those patients, the physician increased the dose of voriconazole, resulting in a higher voriconazole concentration, and 8 of those 11 patients survived, like those that initially had a higher voriconazole trough concentration. The second and larger study comes from Europe and was published just 2 years ago. And this is a study with a much larger group of patients, also patients with mostly invasive aspergillosis, and they found similarly that there were a group of patients that had a threshold concentration, in this case of 1 microgram per ml, that fared better than those that had a concentration below 1 microgram per ml. So again, there are many, many examples of this that take us to this figure, which is as I refer to it, this is the Goldilocks and the 3 bears. So we have patients that have antifungal drug concentrations or accumulation that are just too low, that are subtherapeutic, allowing the fungus to continue to grow. Conversely, we have occasionally patients that accumulate too much antifungal, resulting in toxicity. So this is a toxic level. And hopefully, we can get patients in this area, termed the therapeutic window, where they have just enough antifungal for effective therapy, but not concentrations that are too high and result in toxicity. And this therapeutic window has been demonstrated or defined for each of these 3 antifungals to varying degrees. So itraconazole has been around the longest, and you can see here just from the number of references that I've put on this slide, the most studies have been undertaken. And most of those studies have looked at defining the concentration needed for effective therapy. And when one uses one itraconazole assay, the biologic assay, concentrations that are at 5 micrograms per ml or higher result in a favorable treatment outcome. Conversely, in a study published from Dr. Denning and Dr. Hope's group just this last year, they demonstrated that for those patients that accumulate quite a bit more itraconazole at concentrations greater than 15 micrograms per ml, those patients would reliably experience itraconazole toxicity. You can see here greater than 60% of those patients experienced some sort of dose-limiting toxicity. Similarly, studies have been undertaken, although fewer studies. I don't know if this is now complete. There have been probably about a dozen studies that have looked at voriconazole therapeutic drug monitoring, and they all show pretty much the same thing. So that is when you start to increase the voriconazole concentration here following this red line, one gets to a point that you begin to get to maximal treatment efficacy, at least as it relates to the voriconazole concentration. And conversely, and fortunately, in a smaller group of patients that can get voriconazole concentrations greater than 6 micrograms per ml, you start to run into dose-limiting side effects. We have the least amount of data for the newest of the triazole drugs, posaconazole, and really we only have 1 or 2 studies that have been able to look at the relationship between the amount of posaconazole that accumulates in the body and treatment efficacy. We've not had any studies that have related very, very high concentrations of posaconazole to toxicity. That concentration associated with treatment efficacy of posaconazole ends up being a concentration of about 1 microgram per ml. So there are 3 factors that can impact concentration, at least 3 that I'm going to discuss. The first is fairly intuitive, and that is the amount of the drug that we give our patients. Unfortunately, as I showed you at the very beginning, it's very, very difficult to predict how much drug is going to accumulate for any of these 3 antifungals because of the unpredictable pharmacokinetics, but still a tool we have in the management of these patients. The second factor I'm going to discuss that can impact the amount of drug that accumulates is the amount of absorption from the gastrointestinal tract. And the environment in the stomach, there are 2 features of the environment in the stomach that have been shown to impact the amount of each of these 3 antifungals that's going to be absorbed from the body. And these include administration of these drugs either in the presence or absence of food, and the acidic environment. So our stomachs are normally quite acidic. There are some disease states and some medications that can reduce the gastric acidity and affect the amount that's absorbed. So for the itraconazole pill, taking this with food will increase the amount of itraconazole that's absorbed by about 50%. You need gastric acidity to reliably absorb itraconazole, so taking itraconazole concomitantly with a medication that would reduce gastric acidity will also reduce the amount of itraconazole that's absorbed, again, by about 50 to 60%. You can reverse that effect by administering an acidic beverage, such as Coca-Cola or ginger ale. For itraconazole liquid, remember, as I mentioned, the 2 formulations of itraconazole are different when it comes to concentration management. So in this liquid formulation, actually food has a deleterious effect, so one would want to take this on an empty stomach, and gastric acidity has very little, if any, effect on the absorption of the liquid formulation of itraconazole. Voriconazole is very similar as far as the effects of food and gastric acidity to the liquid itraconazole. This is best absorbed on an empty stomach, and gastric acidity has very little, if any, impact on the absorption of itraconazole. Posaconazole is very similar to the itraconazole pill when it comes to these 2 factors. In fact, food has a very, very large impact on the amount of posaconazole that's absorbed. So any food is good, but fatty food is very good and can increase the amount of posaconazole that is absorbed and accumulates in the body by a factor of 4. Gastric acidity is also important, and with drugs that reduce gastric acidity, the amount of posaconazole that's absorbed can decrease by as much as 50%. So again, maintaining gastric acidity for both of these formulations can be important. The second factor, the third factor, excuse me, that I'm going to discuss as it relates to modulating the amount of antifungal that accumulates in the body is metabolism of these drugs in the liver. As was mentioned earlier, the liver is a detoxifying organ, and very, very commonly, medications are altered so that they're easier to remove from the body. Oftentimes, this alteration can change a medication like these antifungals from a drug that is active to a drug that is inactive. Okay? Hopefully, you're left with enough drug that will accumulate and reduce the burden of organisms in the lung. Occasionally, you can have a situation where the metabolizing enzymes don't work as efficiently, and you can get the accumulation of even greater amounts of the antifungal. Unfortunately, more commonly, at least for one of these antifungals, there are situations in which these enzymes work more effectively, leaving us with a higher metabolic rate and, unfortunately, a lower concentration of the antifungal active medication. So there are two situations that we think about with antifungal drug metabolism that can impact the amount of drug that accumulates. And the first is the enzyme that we're born with. So as was mentioned earlier in one of the questions, there are genetic variability or polymorphisms in some of these metabolizing enzymes. One polymorphism is very common and can have a big impact on the amount of voriconazole that accumulates in the body. Some people metabolize voriconazole very rapidly, resulting in lower concentrations. About a third of all patients in the general population have this genetic predisposition to metabolize voriconazole very fast. The second feature of these enzymes that was also mentioned earlier as it relates to drug interactions. So the antifungals aren't oftentimes the only drugs that these patients are receiving, and some of these medications are also either substrates or recognized by these enzymes in the liver. Sometimes co-administration of the antifungal in one of these medications can block that enzyme metabolism, resulting in higher concentrations of the antifungal. Conversely, there are some medications that can speed up that enzyme. These are called enzyme inducers, resulting in very low concentrations in the antifungal. So how can we use this information to manage concentrations in patients? So first and foremost is to measure the amount of the antifungal that's accumulated in the body. We use the concentration in blood or plasma as a good surrogate for the amount that's accumulated in the site of infection. But the question then becomes, when do we do this and how often do we do this? Unfortunately, I must tell you that there aren't good studies that tell us scientifically when and how often we should measure antifungal drug concentrations. But from clinical experience, this seems like a reasonable list. So I certainly would want to know soon after the start of therapy if my patient had a concentration that I thought was going to be effective. I would want to do this after a change in the antifungal dose or formulation. I would want to know if my patient with invasive aspergillosis was getting worse because perhaps they had low concentration, so if there was a change in disease course, or if the patient was manifesting any signs or symptoms of an antifungal drug toxicity, I would want to check the antifungal drug concentration to see if maybe that was a high concentration may explain that toxicity. So what can we do to modulate the amount of antifungal that accumulates in the body? We can optimize absorption. We can sometimes alter elimination. We can obviously change the antifungal drug dose or dosing regimen, or we can just pick another antifungal. So, from the standpoint of absorption, let's consider each of the drugs. So for the itraconazole pill, we can increase absorption by, again, making sure that the stomach environment is acidic and giving this with food. So we can make the stomach acidic by giving it with an acidic beverage. We can stop or reduce the amount of drug that decreases gastric acidity. From the standpoint of elimination, so this is metabolism, we can avoid concomitant administration of medications that induce those metabolizing enzymes. And again, we can always give more itraconazole. For the solution, we have fewer options. Again, it's hard to optimize. We can give this on an empty stomach, but after we do that, simply avoiding inducing medications or increasing the dose are all we have. For voriconazole, we should give on an empty stomach, avoid inducing drugs, and occasionally, although there's not a lot of published literature on that, we know that there are some drugs that block the metabolism of voriconazole. Sometimes we'll co-administer voriconazole with one of those medications. And again, we can also increase the dose. For posaconazole, we need to make sure this is given with food, especially fatty food, given with an acidic beverage, and avoid acid-reducing drugs. And what we can also do with a drug like posaconazole is give the drug more frequently. It has what's called saturable absorption. So there's only a certain amount at any one time of that drug that can be absorbed. So just giving a larger amount of the drug in one bolus doesn't result in a larger amount of drug accumulation. Again, avoiding inducing drugs and increasing the amount of the posaconazole that we give. Excuse me. So I have two conclusion slides. First, the proposition, should we measure antifungal drug concentrations? And I think for at least these three antifungal drugs in the treatment of invasive aspergillosis, the answer is yes. They have that pharmacokinetic variability, so unpredictable drug concentrations. We have the ability to accurately measure the concentration of each of these drugs. And there's a strong relationship between the amount of this drug and treatment efficacy and sometimes treatment toxicity. Lastly, how should we do this? This is where we're more into art than science. I think it's important or reasonable to measure antifungal drug concentrations at the start of therapy with a change in the antifungal or antifungal dose, and depending on how the patient is doing. If they're faring poorly and we think it's advancing aspergillosis, or they're faring poorly and we think it's a drug toxicity, I think measuring concentration there can be important. If we find a low concentration, optimizing absorption and elimination can be important. If we still have low concentrations, increasing the dose or remeasuring can be important. And if we still have low concentrations, we need to consider the choice of a different antifungal. And I'll end there and answer any questions you might have. Thanks again.
Thank you very much indeed. That was very clear, and I think it'll become clear to many patients who are taking these drugs why it becomes difficult for us as clinicians sometimes to manage them, because it is this seems to be very unpredictable. Do any of these drugs actually affect their own metabolism? Or maybe you mentioned that. I apologize if I missed it. But
I didn't.
What might happen, I suppose, is things change a week after you, or 2 weeks after you've started the treatment.
So that's termed autoinduction, and that has been described for voriconazole. Right. How often that's occurring and how significant that is, I think, sort of remains to be seen, but something to think about as far as when and how often to measure.
Sure. Are there any questions then? Thank you. Anyone in the audience taking itraconazole or voriconazole want to ask some questions? Or did you want to ask about that, or are you happy? David.
You mentioned, and I've thought about it but not done it very much, that voriconazole metabolism is blocked by omeprazole in particular. And omeprazole is used a lot in our patients for lots of reasons. I've had the experience of one patient who had a lot of stomach problems that was given a very big dose of omeprazole of 40 milligrams twice a day and got a life-threatening voriconazole toxicity, was admitted to hospital and almost ended up in ICU. And the dose that we use, as you know, typically varies from 20 to 40 a day. We don't usually use 80, although sometimes that's done. Do you have any suggestions about how we might approach that issue? Because we do have a lot of patients with low voriconazole levels, and in children this is particularly a problem, and it would be sometimes easier just to give them some omeprazole than give them very large doses of voriconazole sometimes. But I don't quite know how to approach that from a omeprazole dosing perspective and the time frames and so on.
So we're doing some of those same things. Unfortunately, all of the information that's available on the impact of a drug like omeprazole and voriconazole in a large group of patients was really the pre-FDA indication studies. And there isn't a study that I'm aware of that's demonstrated that taking this dose of itraconazole or this dose of itraconazole this frequently is likely to have this impact on your voriconazole concentration. I can tell you what we're doing empirically. So we're first, depending on if they're undetectable, we're giving 20 milligrams of itraconazole twice a day, of omeprazole, excuse me, preceding the dose of the voriconazole. If they're just a little bit low, so a measurable concentration, but not yet into the area that we think, so maybe a 0.25 or something like that, where we maybe would like to get more, then we're starting out with just once a day omeprazole. It's something that's begging to be studied, though.
Thanks. There's a question at the back again. Thank you.
Dr. Gray, how frequently are you seeing monitoring liver toxicity in patients who are on chronic azole therapy?
So we're typically monitoring once a month, not because we have good data to say that that's how frequently we should monitor it. It's empiricism. That's at least keeping in mind, I treat the patients with Aspergillosis that I treat have mostly acute invasive Aspergillosis. So whether or not, I guess I would ask David, whether or not a patient that's on one of these medications for years and years, whether or not you need to monitor at all once you've done it for a period of time, maybe that's possible, but I'm just not sure.
I had a trivial question, but it's not trivial to the patients, and that is, if you want to acidify in the stomach, does diet Coca-Cola, is that the same pH as regular Coca-Cola?
I believe it is.
So people, if they're worried about the calories, they can take Diet Coke.
Right.
It's very important to know.
Yeah.
Well, I think you've treated that beautifully, that subject. I think it's a bit of a minefield, really, and even some of us who manage patients don't quite know which direction to go in. So it's one of those areas where we definitely need to agree a sort of a proper guideline so that we can just follow it through.